Good evening and welcome to the Cancer Education Series brought to you by MercyOne and Above and Beyond Cancer. Tonight we're brought to you through a grant that we received from the Iowa Cancer Consortium. My name is Chris Goodale and I'm the Executive Director of Above and Beyond Cancer. It's my weekly pleasure to introduce our founder, Dr. Richard Deming, who will introduce our speaker. Dr. Deming?
Great, thanks, Chris. Welcome, everyone. And we've got a treat tonight. We've got the epidemiologist for the State Health Registry, Dr. Michele West. And I always like to give a little bit of background. Michele is an Iowan. She grew up in Dubuque and went to Wahlert High. She went to Coe College and then got her PhD in preventive medicine and environmental health at the University of Iowa. And as I said, she now serves as the epidemiologist for the State Health Registry of Iowa. And we're going to learn tonight what the State Health Registry is, the role it plays in cancer control, and all sorts of good things. So we're going to have a bit of a presentation, a bit of a conversation. And without further ado, let me introduce Dr. Michele West. Thanks, Michele, for being on.
Thank you. Thank you so much for having me.
And Michelle's going to share her screen. So I'll just take a minute here to get that up and going. And there we go. We can see your first slide plain and clear.
Perfect. Thank you so much. I'm excited to be here and talk to you all about cancer epidemiology and why it's important to you. And I have my email address listed there. So if you end up with questions after the presentation, or if you find a need for cancer data down the road, please just send me an email and I'll do what I can to help. Okay, so the objectives of the presentation tonight are to define epidemiology and the role of the Iowa Cancer Registry in cancer epidemiology. And then I'd like to explore ways that you can utilize registry data, including cancer cluster investigations, our Cancer in Iowa report, and then our online tool. So first off, what is epidemiology? Well, it's the study of the distribution and the determinants of disease and disease outcomes in human populations. So for today, we will be talking about cancer as our disease. And then what is a registry? So a cancer registry is an information system, and it's designed to collect, store, and then manage data on persons that have been diagnosed with cancer. Registries play a critical role in cancer surveillance, which tells us where we are in our efforts to reduce the cancer burden. Surveillance data are also used to plan and evaluate cancer prevention and control interventions, and they also can serve as a foundation for cancer research. The Iowa Cancer Registry has been funded by the National Cancer Institute as part of what's called the Surveillance, Epidemiology, and End Results Program, which we call SEER. And we've been funded since 1973, and we've been consistently recognized for our high quality data. The NCI SEER program is the authoritative source for cancer information in regards to both incidence and survival in the United States. This is just a visual so that you can see for the SEER registries currently where they're located. Iowa represents the Midwestern population, fairly rural. There will be a couple of changes to this for 2021 as a couple of new registries are coming on board. But you can see that different states and different groups were selected for their populations. The SEER program covers approximately 35% of the US population. So there are two main programs for population-based registries. The first is the SEER program that I mentioned that was established in 1973. So this collects both cancer incidence and survival data from population-based cancer registries in the United States. And so for population-based cancer registries, what I mean for that is that we are mandated by Iowa law to collect every cancer incidence in all residents of the state of Iowa. So we have to go out and collect that information, as well as do like state data exchanges so that we can collect the information for people that may winter in Arizona, Florida, etc. So we collect data then on patient demographics. We do primary tumor sites. So if it's a breast cancer or a prostate cancer, the morphology, which means the type of cancer, so whether it's a squamous cell carcinoma, adenocarcinoma. We also collect stage at diagnosis, and then first course of treatment. And by that, I mean that whatever is the planned first course of therapy, it doesn't have to be done anymore in a certain amount of time. It used to be that we would collect treatment for like the first 6 months, but we will now collect whatever is considered to be first course, even if that goes, beyond the 6 months into a year. And then the SEER program also collects follow-up information for vital status. So whether the patient is still living or is deceased. And so you see, I have a couple things in bold there, the stage at diagnosis and the follow-up. Those are the two things that separate the SEER program from the second grouping, which is the National Program for Cancer Registries. And that one was established in 1992, and they collect data from 46 states, the District of Columbia, Puerto Rico, the US Pacific Island jurisdictions, as well as the Virgin Islands. And this program covers 97% of the US population. And some of the SEER registries get funding from the NPCR grouping as well. So the NPCR registries, they also collect data on the occurrence of cancer, and they collect the type and the extent and the location of the cancer, but they are not required to stage their tumors. They also get the type of initial treatment, and then they record vital status and the date of last contact only as available. So those are the couple of differences. So confidentiality of data is extremely important to the operation and the maintenance of the registry. We have confidentiality policies, pledges, and procedures that are all required in phases, in all phases of the registry operation, in order to protect the privacy of the individual cancer patient, the privacy of the facilities that are reporting the case, as well as protecting the privacy of the physician that's responsible for the care of the cancer patient. And then we also provide public assurance that the data will not be abused. So then we're collecting this information, and I should explain that. So the Iowa Cancer Registry is housed in the College of Public Health here in Iowa City as part of the University of Iowa. And we have our central staff, which is here, and then we have our field staff. So we have about 16 certified tumor registrars who have their own territories in the state. We have some facilities that are like COC facilities, the Commission on Cancer, that have their own programs, and they're able to abstract the data and send that data in. But we also have a lot of facilities in the state, the smaller, more rural, that need help with abstraction. So then we have our people out there to help able to get that data in. And so then once the data is in and cleaned up and submitted to NCI in November of every year, then it's like we like to use it to benefit the state of Iowa. And so the first way that we do that is that it provides the backbone cancer data to other statewide organizations. And this can be the Iowa Cancer Consortium, as well as the Midwest region of the American Cancer Society. And then they can use the data to develop and execute a comprehensive cancer control plan. And I have the picture of the current cancer plan that goes from 2018 through 2022. Then with our data, it goes back to 1973, we're able to evaluate trends over time. We can assess the burden of cancer in Iowa, and then we can share these results with the media and the public. And that we kind of do that every year in March when we have our press conference for the release of the new annual report. We can also determine what disparities there are in incidence or treatment and then outcomes that exist within Iowa. And that is one of the main focuses of this year's Cancer in Iowa report that I'll be talking about here in a little bit. And then lastly, we can provide outreach services to the state of Iowa that address the burden and the trends in cancer, and then the potential cancer cluster concerns. And I will be talking about cancer cluster investigations next. But with that, maybe I can stop and we can see if there's any questions that anyone has for cancer registration.
Yeah. Thanks, Dr. West. So I have a few questions for you. So thanks for giving the background of, what is epidemiology and how does the state health registry work and collect data. So back to the definition you gave, and it's really about tracking and determining the distribution and the determinants of a disease. So as a cancer doctor, we have our tumor registry. We're a COC, a comprehensive community cancer center. So the question is, what do we do with the data and how does it provide benefit? So let me have you answer that, and then maybe I can give a practical answer in terms of how, as a cancer doctor, we use the data. But how would you say the data, the collection of the data, ends up providing information that is of benefit ultimately in cancer care?
Sure. So the biggest reason I think that it would provide the benefit is that we have trend data from 1973 to the current year, which is 2018. So I should note that we are kind of a 2-year lag for data. So we just submitted our 2018 data in November of 2020. But you can look at those data and you can see if the rates of any particular cancers are increasing or if they're decreasing. We can look for differences by males versus females to see if rates are dropping. You can look to see if with the HPV infection, and then we can look to see what's going on with oropharyngeal cancers. So it's like as the rates of those infections were going up, we were seeing more cancers, and then you can work then for the vaccine for the HPV. You can look at staging of particular cancers. So colorectal, you could look for areas of the state that have a larger distribution of advanced stage cancers, and then you could work to get some more screenings for those communities. So there's all kinds of ways that you can use the data.
Yes, those are great examples. And in a cancer center, so we are tracking, as Dr. West pointed out, what's the stage of cancer on presentation and what's the initial treatment. And then also we're tracking how do patients do in terms of survival. So you can imagine that as treatments change over time, we can track to see, has the change in the treatment resulted in changes in the cure rate. You also, as a cancer center, we can track our survival rate compared to other centers in the state, to the state as a whole, and to the nation. So you can see how is the quality of the care we're providing, are we getting the same outcomes, and if not, you can do a deeper dive into it. Another piece of another way that the data can be used is to look for disparities. And we're going to, the last part of Dr. West's presentation is to actually present the data that's in the current report. But disparities has really, we've really learned a lot more about that. I would tell you, and either I slept through my class in medical school 45 years ago, or we didn't learn a lot 45 years ago about disparities and what we call social determinants of health. We now know that whether someone develops cancer, at what stage they will present, and how their cure, the chances of curing them is more dependent on their zip code they live in than it is on the genetic code within their cells. Can you maybe explain how this social determinants of health, how that came to prominence through epidemiology and in particular the State Registry of Iowa, and what are some of the ways that we define disparities in the state of Iowa?
Sure, and that was a section that we included in our annual report as well. So there's estimates that up to 90% of cancers are caused by lifestyle and environmental factors. So that takes into account things like smoking, diet, alcohol, and even where, as Dr. Deming said, their zip codes, so where they're living and how their access is to even healthy foods, the opportunity for exercise, access to care is a big one. So we talk about the social determinants for those people that potentially have a lower income or lower education, what this does to their access to care in terms of insurance and even just getting the adequate treatment or having someone to be able to get them for transportation for their treatment. There are other things too in terms of access to the prevention. So the cancer screenings is a big one too, depending on where they live. But those are some of them. They also talked about even just navigating the healthcare system, finding people who look similar to them and being able to navigate the system and having trust in the healthcare system is big too.
Yes, thank you. And as you said, when we get to the third part of our presentation, we'll look at our current, the annual report, and you'll dive into that a little bit deeper. And I think what we're going to turn to next is Dr. West is going to talk a little bit about cancer clusters. What's a cancer cluster? It's not a candy bar. And then we'll have a little bit of a conversation about cancer clusters.
Sure. Okay, so yes, what is a cluster? It's defined as a greater than expected number of cancer cases that occurs within a group of people in either a defined geographic area over a specific period of time. We find that these are commonly suspected with cancer. State health departments receive roughly 1,000 inquiries per year, according to the Centers for Disease Control. And I just wanted to show this newspaper clipping because it's fairly common for people to ignore lifestyle issues that we were just kind of talking about and concentrate on broader issues. So in this picture, if you can see, this is a resident who's worried about the effect on her unborn child from the sound of jackhammers. But in the meantime, she has a cigarette in her hand. But people always like to look for something other than a lifestyle issue for the reason for the cancer. So I just kind of wanted to go through how these cancer cluster investigations are carried out in the state. The Iowa Cancer Registry works with the Iowa Department of Public Health in a cooperative manner. The Iowa Cancer Registry works for the front end, basically, because we have the cancer data. But usually what happens is I either get a phone call or an email, or somebody contacts Dr. Lynch or the Iowa Department of Public Health, who will then contact us. And they have a concern. And it's usually cancers, that maybe they've had coffee and they talk a lot, and a lot of the neighbors are now being diagnosed with cancer and that sort of thing. So they have a particular area in mind that they call me up and they say, it seems like my neighborhood has a lot of cancer. And so I'll talk with them and just kind of see if it's a real defined area. If it's like the entire county, you could always go and look at rates for the county. But if it's a small area, we will talk about getting the area defined, and then we have to choose an appropriate comparison group. So oftentimes, if it's a part of a county, we might do the remainder of the county. Or we can do, if it's a small city, we could do another city that's fairly similar, but maybe in like an adjoining county. And then we also have to talk about the time period of interest. Is it something that's more recent, that in the last few years they've noticed an increase? Or is it something that they want to go back farther in time and look at a bigger area of years? So then what happens is once we have it defined, I will have Dan, who's my person who will pull off those particular cancers then that are in that target area, as well as the cancers then that are in the comparison group. And then I go through and I have a program that it'll go by cancer type, and then you look at the numbers in both the target area and the comparison group. And it runs a SAS program that comes up with what's called a proportional incidence ratio. And we look at those PIRs then to see if there are any that are statistically elevated. And we go through and then we draft a report that will have these tables in there, and that and if anything is elevated, we will add in some risk factor information. And we create this report, and then we'll send this back out to the individual that had the concern. And then we also send one to the Iowa Department of Public Health, to the state epidemiologist, Dr. Caitlin Padati, so that she has one there for her records in case at some time down the road somebody asks about a cancer cluster. She can look to see if we've already investigated one in that particular area. And then, so if the findings support a cancer cluster, then it's up to the Iowa Department of Public Health to outline the future plans. And that could include collecting information from cluster cases about residential and workplace history, family history of cancer, any exposure to known carcinogens. They can review medical and scientific journals to gather additional information, as well as evaluating environmental contaminants. And we did actually have one cancer cluster investigation that we had EIS officers from CDC come up and investigate a brain cancer cluster in the Wellman and Parnell area. And I don't have time to run through the full thing today, but it was a very interesting cluster investigation. So most of the time, the investigations do not confirm the existence of a cluster. And usually the reason for this is that the number of cases is small. So even in the one where we had the Wellman and Parnell cluster, there were 10 total brain cancer cases that we looked at in a few years. But we feel that the resulting health education from these investigations can be an important public service. Usually when we send this out, we don't hear back from the majority of patients or individuals that had asked for one. Sometimes they will contact me in another year when another year's worth of data would have been added in to see if it changes the results at all. Sometimes they will change things up just a little bit, maybe change a comparison group or the different years, and then we can rerun it. But usually we provide one of these, and that seems to calm their concerns. Sometimes Dr. Lynch and I have been asked to present to a group on the results, and so we've done that in the past as well. I just wanted to show you this graphic, which is the 15 most commonly exposure terms that are found in articles that have been listed with cancer cluster investigations. And it's interesting because we have heard from people about a lot of these. Contaminated water, water pollution, pesticides, obviously, since we're an agricultural community. We had somebody that was interested even in the benzene tank and wondering if that had seeped out. So we have, and even radiation, we had a concern about that as well. So we do see quite a few of these mentioned when people call us about a cluster concern.
Dr. West, on this slide, I don't see nitrates listed, and I've seen some articles recently where, you know, we're talking about the rivers and the waters of Iowa and a lot of nitrates from fertilizers. And is that something that you guys have ever been asked to look at? Is the relationship between nitrates in the water and cancer clusters?
Yes, I think that that's one of their concerns when they talk about the water. So then we'll look at those sites that would be affected from the drinking water. Yep. Yep. And then I just wanted to provide as the last couple of slides, we've been doing these cancer cluster investigations. We started basically the year that I got here. And it was funny because once people hear about something new, we had 15 requests for cancer cluster investigations. And we actually had that again in 2002. But since then, you know, over the last 10 years, we've only been conducting a couple of these a year. So the numbers have gone down. But, you know, it's interesting, 143 total, you know, for that time period of 1994 to 2020. So people are interested at times when they feel that something is going on in their area.
And of those 140 some, how many were determined to truly be a cluster and how many were determined not to be a cluster?
Right. Okay. So then once we're done with our investigation, we have 3 colors there. We have the green circle representing no excess found. So if we didn't have males and females both elevated for a particular site, or none of the sex-specific sites elevated, it would get a green circle that no excess was found. And you can see that that's a lot of them there. The pink squares for the excess found would be if there's a sex-specific, so like prostate or female breast or something that was elevated, or if a site, say colorectal, was elevated in both males and females, it would get that square that there was an excess found. And then we also have the code there for CDC notified, and we've had 2 of those since 1994. The one up by Butler County was multiple myeloma, but when we followed up with them, they opted not to have anything further done. And then the other one is down there in Washington County, which is the brain cancer cluster that I talked about in the Wellman and Parnell area. One other thing I should mention is that sometimes we would be contacted by schools or a business that are interested in having a cluster done, but it's just so difficult because they have to get permission to release the personal identifiers so that we can actually link to the registry to see if the employees of a particular place or a school or something have had cancer and stuff. So oftentimes somebody might make an inquiry, but usually we're not able to do those because of those reasons. So these are mostly neighborhood type investigations.
Yeah, so that makes me think of a situation, let's say an example, as you know, and everyone probably knows, there's often a delay from the time of exposure to a carcinogen until cancer develops. So you sometimes hear, I just went to my 20-year high school reunion. You know, people are coming from all over the country to come back, and you find 20 kids in your class over the course of 20 years after graduating from high school developed a certain type of cancer. But obviously, what people are theorizing is that the exposure happened back where they were living up through their first 18 years, but their cancer diagnosis is going to be tracked in a registry where they're living when they were developing cancer. Is that an investigation that is feasible? And have you ever had an investigation like that where it's theorized that they were all living in the same place when they were exposed to the carcinogen, but that the diagnosis is attributed to different geographies?
Right, and it is a limitation because we're unable to account for that. And we said, you know, you're missing some of them, like you said, that have moved away and are diagnosed with cancer, as well as you're collecting some that maybe just moved to the state of Iowa and then they were diagnosed with cancer, but they haven't lived there for their whole, you know, exposure time and stuff. But we haven't been able to do anything with that. It's just a limitation that we're just able to use the Iowa cancer data that we have. Yeah.
Okay, great. Thank you. And I think now we're going to go to the annual report that just came out a few weeks ago that was beautiful, and I've already used it several times in presentations. So we'll go to that.
Okay, great, and good to hear. Yeah, so this is our 2021 Cancer in Iowa report, and I think we can probably put the link up as well so that people are able to find it on our Iowa Cancer Registry website. I also have our YouTube address listed there from our press conference that was held on March 10th, 2021, in case people want to go back and listen to that as well. So our Cancer in Iowa report is pretty much set up in 3 different sections every year. And so the first section is our estimates of our new cancers, our survivors, and our cancer deaths by county. And these estimates are for 2021. So if our report is the 2021 cancer in Iowa, we actually put estimates out for that current year. As I mentioned before, we just submitted our 2018 data in 2020. So this is the only time really that we give an estimate that's more current, that people then can use to look at the burden of cancer to see kind of how many cases would be in their counties. Sometimes we'll get questions from places, even if they think that the numbers of particular cancers, say, that are treated by radiation are increasing, that then they can come and ask us certain information in case they're trying to maybe establish if they're going to need more machinery, that sort of thing. So we do hear from different people as well with those estimates. We also have started to shade our counties to look at urban rural status, and then as well as we give a top 10 sites for new cancers, the survivor numbers, as well as the cancer deaths. And then the middle section then is our special section. And that is the one that this year is on cancer health disparities. Our reports are normally kind of identified by their covers. So we have people that will know what their middle section is just by their report cover. So I wanted to put out there what the middle sections have been in the last 5 years too, if anyone is interested in reviewing those as well. So we've done, last year was ovarian cancer, and then we've done HPV related cancers, obesity related cancers, liver cancer, and then adolescent and young adult cancer. So the middle section is usually, 5 to 8 pages, depending on the topic and depending on, how many graphics and that we have that goes through a particular topic of interest. So people have been waiting for this this topic for years. It's hard to put out sometimes numbers for all of the populations in Iowa due to our small numbers and our efforts to protect confidentiality that I mentioned before. But this year we were able to look at the cancer experience, and we looked at it by a few groups. So we did non-Hispanic whites, non-Hispanic blacks, and then we did non-Hispanic Asian Pacific Islander, American Indian Alaska Native, and then the Hispanic population. Although when we ended up doing the analyses, we ended up having to group the non-Hispanic Asian Pacific Islander and American Indian Alaska Native together so that we had enough numbers to be able to include them in the analyses. So then what I wanted to do for the last time is just to go through our key points from this middle section. And the first point that I wanted to make is that advancing age is the most important risk factor for cancer. Cancer is a disease of the elderly. And so if you think about it, the incidence rate for new cases in any particular racial or ethnic group with a younger population will be lower than in a group with an older population. And what I wanted to show you was these graphics. So if you look at the top left in the non-Hispanic whites, what I want you to focus on is just looking at the top few rows where there's more data there that you can see, looking at like 65 through 74 through 85 plus. You see how those bars are fairly long, and there's a lot of data points there. Where if you look next in the Black population, see how much skinnier in those top rows are, reflecting that there's not as many elderly population, but that they have the larger rows and stuff further down where we have more of a younger distribution. So if you were to just look at those and basically what we said, that cancer is a disease of the elderly, one would expect then that we would find more cancers in our non-Hispanic white population. Okay, so then this figure is what's called a crude incidence rate. And again, so what this does is it just takes the number of cancers in, so we have 5 different time periods there, 1994 through 98, up through 2014 and 2018. So if we had the number of cases in like the non-Hispanic white for that first time period, and if we divided it by the population at risk, we would get then that crude rate. Okay, so that's what we did, was that we plotted it out for the non-Hispanic whites, the non-Hispanic blacks, Hispanic, and then the other category. So it looks like what you would expect it to see when we just were looking at those graphics with the age. So the non-Hispanic whites that had the more elderly population has higher crude rates. Okay, But something that you have to keep in mind is that you can't compare, say, like county population rates or rates by a particular racial or ethnic group without taking into consideration what that age breakdown is in those groups. You know, you can't just compare a population that is very old with a population that is very young. So in order to allow for comparisons between groups, they do what's called age adjustment. So that adjusts for the differences in the age populations in those groupings. And then see what happens in comparing these crude rates then in figure 3 with what we call our age adjusted incidence rates in figure 4. So when you age adjust, now look what happens. The non-Hispanic Black rates are in fact higher than the non-Hispanic whites. And so they have a higher burden of cancer. So it's important for people to remember if they're going to try to compare to make sure that what they're using are the age adjusted rates. And that goes for people in the cancer control and prevention who are comparing either state rates to other states, or it may be that somebody who lives in Johnson County and was diagnosed with breast cancer and wants to know if their county has higher rates of breast cancer than maybe the surrounding counties or the state. So in order to do those comparisons, make sure that you're using those age adjusted rates. Okay. The next point that I wanted to talk about was looking at the age distribution of the cancers. So this is 0 to 39 up through 80 plus. And what I just wanted to point out is that in the 40 to 49 age group, everything is fairly close. But when we start to get to the 50 to 59 through the 70 to 79, the Black population has the higher rates in those particular groupings. So they're being diagnosed with cancer at a younger age than the white population, where we see the white grouping at the 80 plus is the only one that has higher rates with the white population than the Black population. So cancer striking the Black population at younger ages compared to the white population. And then something else that we looked at was all causes of death, including cancer. And what we found was that aside from suicide and liver disease, that Iowa's Black population has the highest mortality rate in every single major cause of death, including cancer. And so then when you combine that with the prior slide that shows how they were being diagnosed with cancer at younger ages, we see that the life expectancy of the Black population in Iowa is 74.8 years compared to 79.3 years for the white population. Okay, and then the last key point that I wanted to touch on looks at males versus the females. And in the males, what we want to look at is the fact that the non-Hispanic Black population has much higher rates than the other population groups. And if you really look there at 1994 to 1998, their rate was almost 400 per 100,000 population compared to the white rate of 250. So there was quite a drastic gap there. But the good news is that you can look over time now to our current 2014 to 2018, and the gap has narrowed considerably. And then if you look at the females, the rates for the Black population were also higher than the other groups, but that gap between them was not near as severe as it was with the males. And then you haven't really seen quite as much of a dropping in the females as you had with the males. But so the good news is that, like I said, the gap is narrowing, but we can't stop now. There's a website that we just looked at that lists the mortality rates for all of the states, and Iowa was second highest still for the mortality rates in the Black population. So we still have more work to do. All right. And with that, I can take a break for that section.
Yeah, it's so very interesting. Obviously, this section has been looking at racial ethnic groups. And how about within a particular racial ethnic group, some of the other determinants such as income insurance education level. Are those things that you were able to look at, or obviously in a 5-page special section, you can't do everything, but would that be an interesting question within a group to see whether you can tease out any of the other determinants and the impact they have on incidence or mortality?
Right. It's a good point. There are the state cancer profiles, and which have in there the 2018 behavioral BRFSS data, which we looked at, but it didn't end up including in the report. But it's interesting because you can look at variables such as current smokers, obesity level, no leisure time physical activity. We also looked at things like the living below a poverty level, less than high school diploma, and that sort of thing. And there were some differences. Let's see if I can look at my notes here because I had these. So like obesity levels for one, the Black population was about 47% compared to 36% in the white, 39 in the Hispanic, 36 American Indian Alaska Native, 30% Asian Pacific Islanders. When we looked at poverty, if those particular 2018 values, non-Hispanic Black, 27% living below the poverty level compared to 10% in the white population. Education, again, there showed a discrepancy. So yes, it is interesting. We don't have, some of these patient-specific levels in the actual registry, and stuff. So you kind of have to rely on some of these other variables at like either a county level, that sort of thing. But yes, it does show some differences in those groupings.
Yeah. So, those who know about social determinants of health, but when we had as the COVID data was coming out and you were seeing higher incidence and excess mortality, and it was like, oh, well, why could this be? And those who track all sorts of diseases were not surprised that incidence and mortality for that disease also had racial variations. And maybe I'd invite you to talk about the fact that we're not suggesting that there is some inherent genetic reason that the Black population has a higher incidence and a higher mortality, meaning they're not cured, but that there is a relationship between how individuals of certain racial ethnic groups, how they live, where they live, how they have access. We're not suggesting it's a genetic predetermination.
No, not at all. Definitely not a genetic. But we can look at those social determinants of disease, and how I mentioned before that a lot of it is access to care, transportation to get to their appointments, early detection, receipt of adequate care due to insurance levels, even survivorship care after they've had their treatment. Again, we mentioned healthy foods, to cut down on the obesity levels and the subsequent comorbidity conditions that may exist that limit a person's treatment options. And again, we talked about just navigating the healthcare system. It was interesting when we had our press conference, we had the co-founders of the Splash of Color, which is up in Cedar Valley area. And it was just really interesting to hear why they created their organization. And really, they just said that, you need to be advocates for those who need it. And you have to be able to give them the knowledge that is needed, especially navigating this whole cancer diagnosis and treatment. It's important.
Yes, excellent point. Was this your last slide, Dr. West, or did you have another section?
Just depended on whether or not we wanted to try to look at our online tool.
Yeah, so we've got about 15 minutes left. And the epidemiology field of science and collecting all this data, it's not just about collecting data and then putting it in a cardboard box and storing it in a closet. It's about how can we use this data to influence how we're going to move forward, where we're going to try to make differences to actually reduce the burden of cancer. So one of the key factors is, again, collect all the data, but how can we have access to the data so that those of us who are not epidemiologists, but are out in the world and interested in trying to see what's the data look like for my county, for my city? How can we have this data at our fingertips? So next, Dr. West is going to show how any of us can access a lot of this data and some really cool tools. So I'll turn it back over to you, Dr. West.
Okay, thank you. Yes, I would say I feel sometimes that people think using the online tools or trying to work their way through data is a little intimidating. But, you know, we have people, I was certainly willing to help anybody with the data, but our online tool is very straightforward. It's pretty easy to use. Let me switch this over to the screen so we can see it. Okay, can you see that then?
Yes.
Okay. So we have a little glitch. Right now, the year end is 2016. It's supposed to be 2018. So hopefully we get that fixed. But I just wanted to walk everybody through this. The first thing here with this data source, you can either do invasive cancer incidence, or you can click and do cancer mortality. So let's go through and just do an example with invasive cancer. And then the numbers are going to come by county, and then you can pick which particular cancer site that you want. So you can either learn to scroll down here, or there's a little bit helpful areas over here. If you know, like you want respiratory system, you can click. And then it's just a little bit easier then that you can say, there's the lung and bronchus that I want. So let's just put in lung and bronchus, and let's just leave it with a 5-year period because that gives us more numbers to work with. And then what you have to do, it kind of will blink at you to say, hit that redraw. So the first thing that you'll see is that you get this graphic with the quartiles from the state. And you can see that the lighter color there represents the lower end of the incidence rates. And then as the colors get darker, those have the higher incidence rates. And you can go to the map and you can just click on any particular county, and then you'll get the information for the 5 years. You'll have your population at risk, your total cases, and then the crude rate. So then it's a nice way for you to just test to see if you know how to create those crude rates is just take, for 2012, take your total cases 38 and divide it by that population at risk, and you'll get that crude rate of 104.04. And then they also give you the age adjusted rate that you need to make these comparisons, as well as the confidence intervals, which helps determine statistical significance. They also mentioned there the statewide age adjusted rate too. So if you want to compare the county to the statewide rate, you can do that as well. I just want to show that down here, then it will give you all of the counties, and they're set up to be from highest to lowest by age adjusted rate. So if you would rather see the low end, it should, there we go. It'll sort it then differently, and then it'll go from lowest to the highest. And then here's your 95% confidence interval. So then you could go back up, you know, and change your sites and stuff. But what I want to show is a really easy way. Say that we just had this one, and you're going to be really interested in a particular county. So let's say we are going to look at Polk County. If you go up here to this 5-year profile, all sites, and give it a click, you won't have to go up there and change to do prostate and lung and bronchus and breast and stuff. You have them all with one click. So if you're interested in that particular county, it'll give you all of the cancer sites. So it's very handy. And you can export if you click this button. So you could bring it into Excel and be able to use it just with one click. So it's very simple to use. And then to just close out of that one, you would go back up and you could click again. So we could say, let's look at prostate cancer. So you could click, get your redraw. And again, you could click on a particular county if you want, but what I wanted to do was scroll all the way down is where you find the state rate. And I just wanted to give people a quick lesson on how you look for statistical significance. So you have to look at the 95% confidence intervals. So let's say you're trying to determine if the county areas that you're working on for some cancer prevention and control have higher rates than the state or higher than another county. You just look at these confidence intervals. So this one goes from 51.25 to 102.84. And what you look for is whether they overlap or not. So the next one listed here is 50.4 and 102.8. So you see how they overlap almost perfectly and stuff. If you had it on like a line and you had shaded in from 51 to 102.84, and then say you used a different color and then found 50 to 102.8, you would look to see if those two colors overlapped at all. And if they did, then there's no statistical significance. But if you look down here, say you were interested in Van Buren and you wanted to compare it to the state of Iowa, you would have 31.13 to 92.85 for Van Buren. But look at how the state rate starts at 102.56 to 106.6. They don't overlap because there's going to be that area from 92.85 up until that 102.56. So if you were looking at Van Buren, you would say that Van Buren is statistically significantly lower for prostate cancer when compared to the state. So if you ever need information, and that way it helps you if you're trying to get funding and that sort of thing that you want to look for places that statistically have issues, then you can use our 95% confidence intervals and look at it that way. Okay. And then say that you wanted to look at mortality, you would just click up, click on mortality. And let's say that we just wanted to do all sites. And then redraw. So you see then that the shading is now blue. So that helps you remember that you're doing mortality. So it's a good way to check to make sure that you've clicked on the right thing. And again, it's set up the same way. You can click over here, say like Dubuque County. And again, you would get that particular information. If you wanted a graphic, you can click on the trend graph. And again, they're really handy to just click on that 5-year profile and get all sites. And that would give you all of the information that you need. Okay.
Yeah, that is very easy to use. Thanks for navigating us through. And, you know, again, to reiterate that that we don't want to just collect data, just have it in a closet. We want it to be actively used so that as we develop public health policy and determine what areas we need to work on, this data is, and this is updated annually, is that correct?
Yeah, so it should be, yeah. So we just, since we sent in our 2018 data, they just added to an online tool called SearStat, which has lots and lots of information on it, but it usually comes out every April. So then once that's available, then the people that update ours will then add the next year's worth of data as well. And yeah, if anybody needs data and stuff, I would tell them, please don't hesitate to call us. We have, you know, data that we can generate for you for various reasons. Try our online tool, see if you have questions, but we're definitely here to help.
So I think we're going to be wrapping it up. I would ask one question and then just let you sort of summarize and maybe tell us what you think is the most important thing, how epidemiology in the state health registry improves cancer control in Iowa. But a question I would have is, we learn relationships over time. So for example, HPV and oropharynx cancer, I mean, that wasn't something we knew. We learn, so there I'm sure are different parameters you track over time because we learn about different significance. What would be some of the more recent additions to pieces of information you track now that 30 years ago you didn't track because we didn't know that there was a relationship? And what's the process by which you change the way or some of the pieces of information that you collect and track?
Oh, let's see. That's an interesting question. I would think, some of the things when people have particular research studies underway where they can focus on a particular interest, that has definitely changed over time. There are more variables that we can collect in the data, things like tumor markers and genetic tests are, I think, a big new one that are being added routinely to SEER data. It's interesting to look at, say, for instance, breast cancer, how the white population has higher rates of breast cancer, but the Black population is dying of it at higher rates, and that they often get more aggressive forms. And that now that we have the different breakdowns, we can look at triple negative or different types of breast cancer or more aggressive prostate cancer. But it's definitely interesting for that, for the genetic tests and the markers that we now are able to collect, to look at that for survival advantages. We do a patterns of care study with NCI every year. And you had mentioned this early on about changes in time for treatment. And that's the focus of the patterns of care, is that they will look at a particular cancer site that maybe they haven't looked at for 5, 6, 7 years, and they'll look to see what's changed in terms of the therapy. And it also gives them a chance to see if those therapy changes are making it to all of the states, like in the Midwest, or if we see some of the more novel therapies more in use in California or the coastal states. So it's very interesting to see if it's being incorporated everywhere, is one of the big things I would think. And I just think, epidemiology, just so many ways to use the data. It's interesting. When I first started this job, I didn't really have anybody who was affected with cancer. I started in 1994, and now I've had several uncles. My mom died of cancer, my mother-in-law. So I think that able to have this information, able to look at treatment differences, what's making a difference in survival rates, trying to determine the best possible cancer given a particular set of characteristics that a person's tumor has, since we know that cancer is a disease made up of lots of different variables, that it's just exciting to try to just keep doing what we can to improve the quality of life as well for people that have been diagnosed.
That's perfect ending. Cancer is a team sport, and it takes everything from a receptionist to a surgeon to an epidemiologist to a navigator to help reduce the burden of cancer. And thank you for sharing with us what an epidemiologist does and why epidemiology is important in helping to reduce the burden for cancer. Thanks, Dr. West.
Thank you. Thank you for having me.
And we'll turn it back to Chris, who's going to take us out. Thanks, Chris.
Thanks, Dr. West. That was very informative. One question I had was 1973 was when you started collecting data. Do you ever reach back any farther than that, or is that just sort of a line in the sand that makes sense for most studies?
That's pretty much where we start. We do have some from like the 1969 through 73. So that data is available there, but 1973 is usually the date that we most often use.
Okay. Well, this was recorded this evening, and it will be on our YouTube page for Above and Beyond Cancer. It will also be on the MercyOne website if you just search for Cancer Education Series. So Dr. West, thank you very much, and we'll let you get back to the rest of your evening.
Thank you. Have a good night.
Take care, everybody.
Bye-bye.